Hi, this is Dr. Inkyong Parrack for another Whiteboard Wednesday. This time we're going to have a little bit of a continuation of carotid surgery. We've previously talked about what it means to have a carotid surgery and why it is relevant in terms of what we do. The whole idea is stroke prevention and preventing some plaque from breaking off and going into your brain. So like we had mentioned before, it's not about increasing more blood flow, although there's some component of that. Very importantly, we do not want any of this material to break off and go to the brain and cause a stroke. And that's the whole idea of stroke prevention and carotid surgery. So how can we get that accomplished? So there are really three ways of doing this, and you can't say one way is better versus the other. Some ways are better for you, and some ways may be better for someone else. So we got to figure out what it is and which one of the techniques are the best fitted for you and why, and then which one you should be getting. So let's talk about some of the differences between them and some examples of why one might be utilized versus another. So the most common way of cleaning this out, which is called CEA or Carotid Endarterectomy. This is the gold standard of surgery. And that's why for so long, nothing has been challenging this, because if the outcomes are so good, why try to come up with something else? Because how can you beat something that's worked so well for so long with such excellent outcomes? We basically we make a incision over your neck, over where the carotid artery is. We get down to the artery, and there are many different things that you need to avoid, including there may be some nerves that you have to avoid, maybe some veins that you have to avoid. But at the end, you get down to the artery itself, you make a cut over the artery, and then I basically scoop all this plaque out. And then once the plaque is scooped out, instead of putting the artery back together like this with a little overlap, which means it's going to get smaller, we actually close it by putting a little patch on it. And the patch could be made up of many different things, and then we sew it together. So at the end of the day, there's a patch that gets sewn in, it gets sewed onto that manner, and everything is now wide open. Not only is it open, but there's no plaque remaining that could crumble off and go to the brain. So the important thing is that we prevent that from happening not only after surgery by cleaning it out, that during surgery, nothing's going to crumble off during the process of it, go to your brain and cause a stroke. Let's talk about the second technique, which also has been around for some time, and this is employed in many different conditions, and it's called Carotid Artery Stenting, or CAS. So the traditional way of doing a carotid artery stenting is going from a remote location, whether it be one of the arteries on your arm or one of the arteries in the groin area, and then going all the way up and finding your carotid artery and putting a stent in its place. It's a great technique once it's done. If you look at 10 years out, the outcomes are the same in terms of carotid endarterectomy versus carotid artery stenting. I don't usually do this for everybody because the stroke risk from doing this is up in the, about 4% for most physicians. So when you say 4%, that's 4 patients out of 100. It may not seem so bad, but if you compare that to maybe 1 out of 100 having a stroke, 3 extra people, that's devastating. So that's why in most instances, this is not the best for everybody. It is good for select patients where any sort of cuts are very prohibited. So why is this potentially a little bit riskier for most patients, especially in our this greater Sarasota area population? It's because in order to get to the carotid artery, it takes on what we said about circuitous route to get there. We're not going directly on the carotid artery. We're going from the groin area or the arm area where we're hitting the rest of other blood vessels called the aortic arch. And as you get older, the more and more age you get, there's a little more evidence that you have more plaque disease in those other parts, because if you were building plaque in the carotid artery, you probably have some plaque in other parts. As you traverse with wires and stents and whatnot to get to the carotid artery, you're kind of disrupting some of it. While you're trying to put the stent in, you may actually have some of these carotid plaque embolization, meaning that AKA translates to a stroke. A lot of times what we try to do is put a shield in this area, meaning if we were to put a stent there and balloon that open, we put a shield distal to that to catch some of this plaque. Unfortunately, if we were to scan everybody's brain that's gotten the procedure, upwards in the 60 to 80%, you will see some escaped plaque material that has gone to the brain. A lot of times it doesn't cause any immediate issues. Over the next 5-10 years, the data is a little bit more grim that this may contribute to some dementia, some significant notable decline in cognitive function, and overall outcome is poor because of that. And so these are all a little bit more controversial sides, but this is some of the reasons why we're very selective in terms of suggesting one versus another. The other one is called TCAR, which is Transcarotid Artery Revascularization. It basically combines kind of both. When I first heard about this technique, I thought it was a little silly because you're getting a cut, but you're not cleaning it out. You're doing some sort of a stenting technology, but it actually combines some benefits of both to provide as an ideal outcome, just kind of like carotid endarterectomy. So basically, the cut gets made a little bit more in, discrete location, just over the collarbone where you have a little bit of skin crease anyway. And then goes in a sheath or a device, and through that you basically crack this plaque with the balloon. All of that cracked plaque and blood gets sucked out of the body, and then the cleaned up blood then given through the groin area, which there's a IV that's put in. All of that device gets taken out before you're done. Once that happens, we lay a stent in its place because everything got cracked out and it's now clean. Surprisingly, the outcome has been short-term as well as long-term outcomes. It's equivalent to carotid endarterectomy. So there's really no huge difference between CEA and TCAR in terms of short-term and long-term outcomes. What does this boil down to? This boils down to there are different portions of your anatomy and your plaque characteristics in terms of whether you have significant calcium-heavy plaque, do you have a little bit more fatty, fibrofatty plaque. All of these should take into account, as well as the length of your carotid artery, how far away is from the base of the neck. That should be calculated in determining one of these three techniques that would be ideal for your treatment. When that is determined and when you get treated with your ideal treatment, that's when the outcomes are the best. And this has been proven. Institutions and places where all three techniques can be offered have the best outcomes. If only one technique is employed, then the outcomes are not as going to be good because you might be better suited for one procedure for your specific anatomy. In summary, carotid artery, disease can be repaired in many different ways in order to prevent stroke. And knowing your anatomy and having it evaluated and knowing your plaque morphology and having it evaluated is crucial in terms of your outcome. This was Dr. Inkyong Parrack again for Whiteboard Wednesday. See you next time. Thank you.